Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. As today, we're going to talk a little bit about small cell lung cancer. We have a great faculty today, Dr. Christine Hann from the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University School of Medicine in Baltimore, my hometown, Christine, incidentally, and Dr. Jacob Sands from the Dana-Farber Cancer Institute in Boston. Today, we're here to talk about small cell. Up until a few years ago, not that much to talk about, and then boom, a big explosion like you see in oncology. We will be talking about the use of unapproved agents and regimens today, so check out the available package inserts for more information. As with all of our year in review programs, I met separately with the faculty in the last couple weeks to record a presentation reviewing some of the key papers of the year. There's a link to both of these presentations in the chat room if you want to check it out now, but then we'll send it out along with the recording of this webinar for the definitive program. We really view this as a three-part program. Watch the two presentations to find out what was presented this year. And then tonight, we're going to talk about what it means to clinical practice and to future clinical research. Here are the papers that the two faculty reviewed in their presentations. We have a few of the slides that they showed here tonight, but we're really going to chat more about the implications of them. I really recommend you check out both of these presentations. They're really excellent for more details. So here's where we're heading. We're going to start out with a little bit of an introduction about small cell. Then we'll talk about some of the papers in the past year in limited stage, extensive stage. I want to slip in a couple comments about paraneoplastic syndromes because I saw an interesting reference there in Jacob's CV. Well, of course, we'll be talking about tarlatamab, but also antibody-drug conjugates, particularly IDXD, ifinatamab deruxtecan, and then other agents, including the beginnings of CAR T therapy. But before we get started, faculty, I just want to take a breath and tell you a little bit about what happened to us last weekend. We actually were in Puerto Rico for the Society of Gynecologic Oncology meeting that we go to every year. We did 4 programs there, and I want to share a couple of observations from this past weekend and see what you in the lung cancer field think about it. A little bit outside your field, but I think kind of reflects kind of the siloing that goes on in oncology. We started out with endometrial cancer, where we talked a lot about IOs. And just interestingly, IOs came into endometrial cancer in 2023. So in contrast to you guys in lung cancer, this is more new, and particularly endometrial cancer. Then we went into ovarian cancer, where their first positive trial of an IO that we talked about there was just at the ESMO meeting. So now we're trying to figure that out. They've also got to sort through, in the platinum-resistant situation, relacorilant, the glucocorticoid receptor antagonist that's used with nab-paclitaxel. I don't know if that's ever going to come to lung cancer. Then we talked about ADC, something we're going to talk about here today. And again, it was very interesting because one of the things that was discussed there was TROP2 ADCs, which right now there's nothing approved. There's not even a positive phase 3 right now in gynecologic cancers. And the faculty was really kind of struggling a little bit about what to anticipate in terms of side effects. And I'm sitting there thinking, like they were talking about sacituzumab side effects. Our audience obviously completely is aware of that. And then finally, and this is something I've seen over and over, and I'm curious what your thoughts are, we did a program on HER2 gynecologic cancers. And one of the things we brought up was the fascinating work going on in non-small cell with TKD mutant lung cancer and the recent approval of 2 TKIs, cevabertinib and zongertinib, none of which the GYN people had ever heard about before, and it was news to them. So I just want to start out with you, Christine. Any thoughts about how you as an investigator try to keep up to date with what's going on? There's so much going on in oncology. Any thoughts about what you just heard about from the SGO meeting?
Oh, yeah. No, that's so exciting to see immunotherapy enter the space. We had hints of it. I try to, in our institution, we do try to engage in grand rounds and just get annual updates, but it is hard to keep up. But we get hints of it along the way. It's very exciting to see the first large-scale studies being reported and the data coming out of that.
Jacob, any thoughts? We find a lot of times investigators are watching our programs and we invite them to speak on our topic and they sit in the back and watch, I guess, trying to get ready for the boards. Any thoughts about this? You think zongertinib is going to end up being used in endometrial cancer at some point, or gynecologic cancers at some point?
Well, I think this is one thing is in the community where you're treating so many cancers, I can't imagine how to try to keep up on everything. But here's a scenario where they have actually experience with a drug that now is new to a space. And we saw that with the beginning of antibody-drug conjugates in the lung cancer space, as many in the community already had some experience with these, and we were catching up. So now it sounds like in the GYN group, they're catching up to some of what's happening in other fields.
All right, well, let's get back to small cell. And before we get into some of the papers that you two presented, I just want to take a breath a little bit and get a little bit into the biopharmacology of small cell. When I think about small cell, I think about somebody who's smoked a lot, has a lot of mutations, but also obviously a very rapidly aggressive disease. And this is kind of like the game show Jeopardy. The answer is wildfire sparked in dry grass. And what's the question? So actually, I was telling the faculty, the question is, what happens if you ask ChatGPT to come up with a good metaphor for small cell lung cancer? And in fact, you get the same answer and pictures when you ask Google. But just kind of be a little bit funny here, Christine. But I'm curious what we've learned about why it is this disease is so rapidly aggressive. If there's any molecular explanation for it. This is a slide that you showed, Christine, in your presentation, just looking at targets in small cell. I used to think about small cells just as wild animal that we couldn't control, but, responds to chemotherapy. But any thoughts about the biology, what's going on here, Christine, why it is so aggressive?
Well, I think among cancers, loss of P53 as a tumor suppressor gene is fairly common. In small cell lung cancer, loss of both RB, another tumor suppressor gene, and P53 is kind of defines most cases as well as defines the preclinical models. So I think it just takes one more step after losing those key components that control cell growth to then let a cell go free and rapidly proliferate. So that might be the cornerstone, and then, of course, added molecules or expression of different proteins that then also can feed forward to rapid growth and dissemination of tumors.
So, Jacob, I don't know if you want to add anything onto that, again, in terms of just the biology of why it behaves the way it does. And also, I have to ask you, because I know you're such a great advocate for lung cancer screening, is there an impact of screening in terms of small cell?
So thank you for that. P53 and RB1, I think these are essentially, I describe it like the brakes being broken on the car. So you get the car really careening forward. And then when you have things like c-MYC overexpression, that's like the gas pedal being stuck down as well. And these kinds of genomic alterations, I think, are what leads these cells into being so aggressive. As to lung screening, I think the benefits of lung screening in the small cell space are grossly underappreciated. That what we have right now for lung screening data are big studies where screening was just done for 3 years and then not done for a decade after, and that data is all collected. And in those, you're not capturing the real benefit of lung screening. And those studies that truly show a benefit that led to approval and recommendation are still underrepresenting the value of screening. But in a robust lung screening program, we see about 60% of small cell being diagnosed in the limited stage. So there is truly a benefit to lung screening for small cell. Broadly, the best thing we can do for all of cancer mortality is for all those who qualify to get screening scans. I think the appreciation for the impact of screening is grossly underappreciated.
So speaking of limited stage disease, we're going to start to get into some of the papers that you reviewed. And Jacob, you reviewed 2 papers, really one new one, which is this NRG study in limited stage disease, chemo radiation plus or minus atezolizumab. We also saw at the last year's ASCO meeting some follow-up from the Adriatic trial using durvalumab, where we saw such a remarkable improvement, not only in PFS, but overall survival, almost 2-year difference. But Christine, when Jacob presented the data, interestingly, this Atezo study was flat out negative. The trials it overlapped. So, I was mentioning that ovary, just after a whole bunch of negative studies, got a positive trial. Here we had a very positive trial, and now along comes a negative one after that. I asked, so when Jacob presented, I was asking for his theory about why, and I'll get to that in a second, but I'm curious what your thoughts are. One thing was they did give the Atezo during chemoradiation. I don't know if that explains it. What are your thoughts, Christine?
Yeah, I think the initial discussions were that because with giving atezolizumab during radiation, you really mute any kind of immune checkpoint related response, whether it's for draining lymph nodes that are affected, and that's really where the T cells are matured and activated in order to be enhanced by the effect of an immune checkpoint inhibitor. And we saw parallels in the non-small cell space in Pacific 2, where, again, concurrent immunotherapy with chemoradiation was not beneficial compared to as consolidation. So not a real surprise, but it was unfortunate. But I think there's a lot to learn. They collected a lot of samples on the study, and maybe they can answer even more questions for us about the patients who do benefit or don't.
So, Jacob, any thoughts? Maybe any further explanation about theoretically why there would be some kind of antagonism between IO and radiation therapy? Also, we've always kind of, I think, viewed PD-1 and PD-L1 agents as being equivalent. But there are a few situations out there where we've seen, one PD-1 works, one doesn't seem to. Any thoughts about what's going on here and your speculations about interaction between radiation and IOs?
I think it's hard to know. Some of the speculation around the radiation essentially limiting the effect of the immunotherapy is that you have a whole bunch of immune cells throughout the lymph nodes in the chest, and when those are being radiated, maybe we're eliminating those cells that are supposed to then have that immune effect. So that could be why. Now, that being said, there was another study that followed of atezolizumab after chemoradiation, and that was also completely negative. As for the PD-L1 and PD-1, I sometimes hear that now in the small cell space saying, well, the PD-1s don't seem to work, but actually they do. When we're looking at the median progression-free survival and the median overall survival, and we have drugs that work overwhelmingly well for a subset of patients, we don't necessarily see a positive trial from those medians. That being said, in the first-line extensive stage with Pembro, the p-value on overall survival was 0.02 something, but they had limited their alpha based upon the PFS and OS. And on top of that, there was one patient randomized to Pembro that got placebo. And when they reanalyzed by what patients got instead of what they were randomized to, the intent to treat, that could have been a positive trial. On the tail of those curves, we also see real benefit. And this is the shocker to me, is these atezolizumab trials in the limited stage setting, okay, didn't meet the median PFS OS benefit, but the tails of the curves also don't really look any better. And that's quite surprising to me.
Christine?
Oh, yeah, I think just adding to what Jacob just said, I agree with that. I think that the PD-1 and PD-L1 in the extensive stage setting are very similar to the point that if there were a trial or trials are run, I'd feel very comfortable, I think all of us, if Pembro were on the control arm or Pembro was combined with something else. There's not enough difference to say that PD-1s shouldn't be further investigated in this space.
So I also want to recommend to the audience, there was an ASCO Rapid Recommendations on Systemic Therapy for Small Cell that has some pretty cool algorithms for you to take a look through. But I also want to ask you about this question. It comes up all the time, not only in limited stage, but extensive stage, which is the issue of PCI, prophylactic cranial irradiation. Jacob, what's your current approach in your own practice outside a trial setting to this question? Again, a limited and extensive stage disease. Any thoughts about this Maverick trial?
So this has been anticipated for years now. I'm looking forward to seeing Maverick data. There's also a study in Europe. We had the data in the past for limited and extensive stage suggested an overall survival benefit with radiation, but those were not done with an MRI of the brain at baseline. So chances are we're treating a lot of people, not necessarily prophylactic. We saw an extensive stage study in 2017 with an MRI brain done at baseline. And if anything, there's a trend to better survival in the group that got Q3-month MRI brain rather than prophylactic cranial radiation. So, what that tells me is that all the studies we had before in the extensive stage setting were likely wrong, which now people say, well, in the limited stage setting, all we have is these older studies. And I say, okay, but I think we know now that that paradigm was wrong. So to me, it's really a question in the limited stage setting whether we're potentially hurting people from doing radiation even. Now, I think by and large right now, people are leaning toward giving PCI. This is why I really am so anxious to get this data from Maverick and others. Now, the primary endpoint, I think, was changed in this study. So it may not be overall survival, but it's now related more to toxicity. But I think we will see what the trends of those curves look like and get a sense. Does it look like there's maybe some hint of benefit from the PCI or not? These patients that end up being cured, which obviously is the goal when we're treating aggressively in limited stage, they're the ones that years out, I worry about the toxicities of the radiation more in that population too. So, ultimately this comes down to patients' discussion with their radiation oncologist. But I certainly lean away from it in the extensive stage setting. But even in the limited stage setting, I'm questioning the benefit and looking forward to having data.
So this is a slide from Christine's presentation. We're about to talk about extensive stage disease. We're going to start out talking about where we are today and quickly move to where we might be in the next year or two. Anything you want to say about this paradigm? I guess we're about to talk about the most recent addition to this algorithm with the IMforte trial, but now with the tarlatamab as standard second line. Christine, anything else you want to say about this current landscape?
Yeah, it was great to see this data. I think for certain subsets of patients, lurbinectedin is a reasonable choice as maintenance. It's a tough drug, I found, for my clinical practice, but in someone who has done well with etoposide platinum and ICB and are interested in further treatment, then I think starting lurbinectedin is a reasonable option. One caveat to the study is patients with brain mets or known brain mets were not permitted on study. And so I think that's one thing to consider since lurbinectedin does not get good blood-brain barrier penetration.
And we'll take a look at the data just to remind you all of what was seen. I think people are pretty familiar with what happened here. But I hate to spring this on you, but I should have told you this ahead of time, Jacob. But this is a slide. I'm about to do a recording with Dr. Martin Reck. And I noticed this slide in his slide deck about I always thought of lurbinectedin as just chemo, but he puts out a bunch of other issues here in terms of potential impact on the microenvironment and immunogenicity. Any thoughts about, is Lurb just chemo or more than that, Jacob? And what do you do in your own practice right now in terms of maintenance therapy?
Well, I'm so glad you're showing this actually, because this is part of the hypothesis around the synergy with lurbinectedin and checkpoint inhibitor. And on the bottom left there, you're showing the tumor microenvironment and impact on tumor-associated macrophages. And by causing apoptosis of these tumor-associated macrophages, you're reducing the inflammatory signals and VEGF and such. And the idea is that by clearing out these cells that may be stimulating the tumor and instead allowing for infiltration with immune cells that can have an attack on the cancer effect, that may be how we get synergy. Unfortunately, what we've seen from the overall survival curves with IMforte is that those curves come together. And so to me, synergy would have represented the tails of the curves maintaining separation, essentially that cancers that were not going to respond to immunotherapy now seeing those responses. In those first curves, the progression-free survival curves came together in the tail, but overall survival did not. But now in the mature data, both progression-free survival and overall survival curves come together. So I don't think we're seeing synergy. What I think we're seeing is an additive effect, which is why we get such clear separation of the curves in the middle there, is that lurbinectedin is having kind of a second-line effect earlier on.
So, Christine, any comments on that? I was all excited after ASCO, as Jacob said, the curves look really good there at ASCO, and then just a few months later with more follow-up at the ESMO meeting, you see what he's just talking about in terms of the curves coming together. Any thoughts about this? I guess the other thing it brings up, and you can see it here too, and we've been making this point, Christine, is, I think, obviously extensive stage small cell is a very difficult disease to manage, a terrible, overall survival. I think in the 2 IO trials, the median survival is like around 13 months. But the one thing that I just became personally aware of, I started to hear lung people talking about, and really in the last, I'd say 6 months, is the tail on the curve here. And I was actually bringing this up to Dr. Coletta, who did the ovarian study, because her data looks a lot like yours did in the beginning. And I was telling her about how, as with more follow-up, it looks like you have maybe a 12% or more, I don't know if you want to call it cure, but say 5-year survival. Any thoughts about lurbinectedin in maintenance and what happened here as the curves came together? And also, Christine, in terms of the goal of therapy, to me, if you have even a possibility, even if it's only 12% a cure, it kind of changes maybe the way you think about how aggressive. Is this really just palliation, or is this attempt to go for cure? Any thoughts, Christine?
Yeah, I think as we've used more immune checkpoint inhibitors in clinic, I've definitely had patients who fit in this 12 to 13% maybe plateau. And so it's very exciting to see patients are doing well long term with very few side effects. So the difference between, the curves come together, so the benefit really is mediated by immunotherapy. Lurbinectedin is temporarily helpful, but it's worth trying for immune checkpoint inhibitors because there are a subset of patients who will do well long term, and it's real. I see it. We're following patients who are following this curve at the 12%. Lurbinectedin.
I'm sorry. Go ahead.
No,
Go ahead.
I said lurbinectedin is a different story. I think it's really for select patients who want to try anything and have done well on chemo IO induction. But we use it very little. And I do think that up and coming, hopefully as we get more data on tarlatamab in the maintenance setting or even other agents, that we'll see even better numbers that do have a more durable response.
Anything you want to add to that, Jacob? And also, I was thinking about it. We're going to show this later. The initial data looking at tarlatamab in the maintenance setting that's so exciting. But I was trying to think about what happens to the immune system if you give a CD3 bispecific and a PD-1 agent at the same time. I guess they're different parts of the immune, or they interact. Jacob, any thoughts?
Well, so that'd be hypothesizing around like Delphi 305 is giving a T-cell engager that binds CD3 and DLL3 along with durvalumab in the maintenance setting. I don't know that I would expect synergy from that necessarily, but even additive benefit of 2 immunotherapy agents looks like it could be pretty astonishing. What we see from, the Delphi 303, which was an earlier kind of phase 1B study. Specific to your question, I don't know if it's going to lead to some kind of synergy or activated immune system that leads to then more of this directed CD3, DLL3 effect. We all hope for that. It always feels a little bit hand wavy when we talk about these in general, because in the end, it's really a matter of, okay, does the clinical data demonstrate that? And it'll be the tail of the curve on these studies. Do we see 3 years, 4 years out? Do we have more of these patients? Because in an additive effect with the DLL3, CD3 bispecifics, trispecifics, we see 2 years of disease control or longer in these already. So if we're seeing tails of the curves, we're going to have to look out 4 years.
So, and again, I think it's going to change the way people look at SMUD as we move forward. You see more and more encouraging data, how people view this disease. I want to bring up another issue. This came out when I work with faculty. We always do look through their recent publications, and I noticed there was an effort there, initiative at Dana-Farber looking at Eaton-Lambert or Lambert-Eaton, and I thought it might be. I've always kind of wondered since IOs came out where IOs and paraneoplastic syndromes intersect, if at all. But also, I was wondering whether or not there's a lot of awareness out there about the diagnostic tests that you need to do to diagnose Lambert-Eaton syndrome. Anything you want to say about this effort at your place, Jacob? Anything you want to say about the workup and maybe the challenges of diagnosing Lambert-Eaton just clinically in terms of, versus proximal muscle weakness just from, whatever, corticosteroids, wasting, et cetera? Any thoughts or comments, Jacob?
Well, anytime we talk about LEMS or Lambert-Eaton myasthenic syndrome, I get chest pain because this is symptoms that are just so common within our population. And so I worry, is that have anyone who's had proximal muscle weakness, have I appropriately considered LEMS in those patients? Or is this something where it's like, well, it's so common, it could be from the disease, it could be from the treatment. Have I missed people? And I worry about the cases that I might have missed. Afshin Dowlati at Case Western, it really, he is one of the most impressive oncologists I've met, but he has tested a lot of people as well. This is something that he's had at the forefront of his mind and certainly experience with these patients. And so our effort in putting together a study was really just a way of trying to capture what is the true incidence of this diagnosis of LEMS associated with small cell, and how can we get a more accurate representation of this, because there is a test for this. Now, the VGCC test or the voltage-gated calcium channel test, you can send that specific test, or you can send a paraneoplastic panel. But we're looking to just send this test on hundreds of patients as a way of getting a representation of how many people have this diagnosis. But if they have a positive test, then they'll see a neuro-oncologist or a neurologist. We'll follow the pathway. This is not a study around the management, but more capturing the incidence of what's thought to be really quite rare. But I don't know that we have a great representation of how common it is, due to people have to think about it to test for it.
So, Christine, any comments? I think Jacob said to me there's a better prognosis in patients with Eaton-Lambert syndrome. What have you seen in terms of clinical presentation, Christine? Is it challenging to diagnose?
Yeah, agree that it's underdiagnosed. Probably patients have mild or moderate symptoms that really speak to LEMS that we're not recognizing. I will say the most poignant cases I've seen have been those patients who presented with this, maybe even other neurologic paraneoplastic syndromes, had vanishingly small amounts of tumor. It was actually the last test that they had, maybe a PET scan that identified it, and they had good outcomes because they had relatively early stage disease. I think that is different across the spectrum of neurologic paraneoplastic syndromes, but I've certainly seen it with some LEMS patients who, at least from an oncologic perspective, did well long term because their cancer was found early.
So, of course, Jacob, the best way to treat a paraneoplastic syndrome is shrink the tumor down, obviously. But I'm curious whether or not we see any interaction between IOs, at least initially, in terms of worsening paraneoplastic syndrome. Is that, obviously we have SIDH and, other paraneoplastic syndromes. Any evidence that IOs make that worse in the short term?
I think there's still a lot we don't know in this space. So it does make me nervous, depending on how severe their symptoms are. At the same time, it's the treatment of the cancer itself that is what's most helpful. But if you're inflaming the immune system and getting kind of a broad immune effect, could that worsen some of these? I worry about that. Now, I worry about that more in like the checkpoint inhibitor space, where we get broad immune activation, as opposed to like tarlatamab or these T-cell engagers, where I think what we're seeing is still a more focal immune response. That being said, that's not to say that we really have a lot of data to back up what I'm describing as far as outcomes. I'm saying I'm a bit more willing to use some of these drugs even in patients where I'm worried about an immune kind of inflammatory effect. But still, a lot we don't know.
So, question from the chat room, Christine. We do a lot of surveys. In the last small cell program, we did a big survey of general medical oncologists, and one of the things that we saw there was that people kind of have their favorite IOs. We were asking, what do you usually start to use, Atezo or Durva? And, people were saying, well, I'm used to using one versus the other. But we also asked them, once the Inforte data came out, and the question a lot of them were asking us is, if we start Durva, is it okay to use LIRB maintenance? Obviously, the trial used Atezo, but Christine, have any thoughts about Durva LIRB maintenance?
Yeah, I personally, I wouldn't have a reservation about using lurbinectedin with durva rather than atezo. I know the study was done with atezolizumab. I don't know if there's any issue with insurance reimbursement in terms of the formal FDA approval, but I think mechanistically, I would feel comfortable. We tend to use
Another,
atezo, so we get away with it.
right. So maybe we can move on now and talk about tarlatamab. Lots of questions about that, particularly in terms of who's going to give it and where it's going to be given. Maybe we can start with you, Jacob. This is actually, I think, as Christine's summary of where things are heading, and starting out with tarlatamab. Can you talk a little bit about kind of what T cell engagers are, what DLL3 is, where it's expressed in addition to small cell cancer, and how tarlatamab works?
Yeah, DLL3 is very common in small cell lung cancer. In the tarlatamab studies, it's been about 95% of the tumors of those individuals enrolled to the tarlatamab arms. So very common in small cell. But it is also present in other neuroendocrine carcinomas. And so tarlatamab is a bispecific T cell engager, binds CD3 on T cells, binds DLL3 on small cell lung cancer, and pulls them together, creating an immune response. Now, tarlatamab has really just been studied in small cell lung cancer, but obrixtamig, another bispecific T cell engager, also to CD3 and DLL3, has enrolled broadly across other tumor types, including large cell neuroendocrine carcinoma, where low numbers, but a reported 70% response rate, 7 out of 10. It was 10 cases and 7 responses. So 70% response, but low numbers. Gocatamig, or MK6070. This was initially HPN 328, a drug by Harpoon that was bought by Merck, now called Gocatamig. This is a tri-specific T cell engager. CD3 and DLL3 also, but instead of an FC region, has a binding to albumin, and this also has enrolled patients with tumors across multiple neuroendocrine carcinomas, and as well as small cell prostate cancer. Now, the responses we've seen have really been the most in number and durability in small cell lung cancer, but certainly compelling data in large cell endocrine and other neuroendocrine carcinomas, and to a lesser extent in small cell prostate. But small cell prostate has such limited options that at least my colleague who leads small cell prostate has highlighted that this is really a very important option within prostate cancer as well. And so based upon those other data, tarlatamab is the only T cell engager that's currently approved for these solid tumors with DLL3. And my colleagues in GI and GU have been using tarlatamab based upon the data from these other T cell engagers. So it is starting to see more broad use, and the responses can be quite durable.
So you have this sort of faint memory of an ADC, I think it was called Rova-T, that was against DLL3. But I think that there it was like toxicity that I think was the problem and never really got off the ground. Obviously, a lot of other ADCs out there. What do we know about the efficacy? Here's the Delphi 304 study, Christine. I don't know whether it was a surprise to you or not, but it certainly was a pleasant finding. Any comments?
I think we saw hints of this early on when early data was presented. So not quite a surprise, but a really welcome confirmation of the earlier Delphi 300 and 301 studies. A median overall survival, 13.6 months versus 8.3, and the control arm was patients who received topo, lurbinectedin, or amrubicin. So really a global study. Most patients on that control arm did receive topotecan because that's more widely available, but nonetheless, clear benefit. And when patients get beyond the first couple cycles, I know you're showing toxicity. So the expected toxicities for the control arm of chemotherapy, which are mostly hematologic, and the expected toxicity for tarlatamab, which is CRS, which is cytokine release syndrome that we see with other T-cell engagers, and early on. So this toxicity happens early on, usually within the first cycle. But then after that, if patients are doing well, I find that they do quite well very long term, maybe with the exception of dysgeusia. That I think ends up being probably my biggest complaint from patients who are on long-term tarlatamab.
Dysgeusia and tarlatamab. Maybe I'm the last person to know about that, but I haven't heard that one before. Anything you want to add to that, Jacob? And also, when I first heard about, after seeing CD3 bispecifics in myeloma and lymphoma, which, of course the CRS is not as bad as CAR-T, but it's still pretty substantial. I was imagining it as a very sick small cell patient, huffing and puffing in his bed, having cytokine release syndrome, but turns out it hasn't been anywhere near the problem, at least I thought it was going to be. Any thoughts, Jacob?
Yeah, that's right. The CRS, as I'd say, is scary until you're treating patients, and then you find that it's pretty anticlimactic. The majority of patients have symptoms that are easily manageable. Now, sometimes it can be severe, and so that's not to say that there aren't some cases that make you a little nervous, but for the most part, this is really quite manageable. I just want to stress, too, though, that Delphi 304 is the only trial in existence in the second line of small cell lung cancer that is a positive trial with a therapeutic control arm. There's only one other randomized trial I'm aware of that's positive, and that was topotecan PO versus best supportive care. And I don't think those curves even separate out as much as these curves do. Topotecan IV was approved versus CAV in curves that entirely overlap. Lurbinectedin was FDA approved from a single arm trial showing a response rate of 35% and a median PFS of 3.5 months, median overall survival of 9.3 months. So this is something that won in progression-free survival, in overall survival, in toxicity profile relative to chemo. Tarlatamab was better. In symptom improvement, it is across the board a sweep of a positive trial. And I highlight that because I know there are centers where we say, well, this is inconvenient or we don't have access, and I think everyone needs to find a way to get patients these drugs because this is an overwhelming positive trial like we have not seen in small cell lung cancer.
And adding to that, Christine, is the data. One of the most common questions we got in the beginning from oncologists was, what about CNS activity? Of course, with small cells, such an important issue. I don't know if you were surprised or not, but it seems like it's pretty effective in the brain. Any thoughts, Christine?
Yeah, very exciting data. Really addresses a major issue for our patients with small cell lung cancer. When they develop brain mets, really hard to treat. If they've already had whole brain radiation, you're not left with many options. And intracranial responses were seen across, I think, both dose levels, but certainly at the 10 milligram dose, and a significant proportion of patients. I think, depending on the series you look at, over 60%, in some cases even higher levels in smaller series, but amazing to see an actual RANO criteria tumor shrinkage. But I think even beyond that, stabilization or less than 30% shrinkage can really have clinical benefit. So very exciting.
So, Jacob, this is what we were talking about earlier, the Delphi 303 study, looking at tarlatamab with an IO, both atezo and durva. And, of course, this is not a randomized phase 3. But anything you want to say on what's been observed up to now, Jacob?
I mean, this is extraordinary. We see a 25.5-month median overall survival in this first-line maintenance study. If you add on the probably 3.5 months of initial induction, this is like 29 months of these patients from when they started therapy for metastatic disease, 82% survival at 1 year. For frame of reference, that is about 30% absolute better than what we see from Inforte, which we just highlighted as a positive trial relative to just maintenance atezolizumab. So this is a study that kind of blows everything else out of the water. And Delphi 305 is a randomized trial of maintenance durvalumab versus durvalumab plus tarlatamab. If that study looks anything like 303, this will become the definitive first-line maintenance standard of care, further highlighting that anyone treating small cell lung cancer needs to make sure their patients are getting access to tarlatamab in some way or another.
And again, you can check out Jacob's presentation for more of some of these other bispecifics that are also out there, DLL3, obrixtamig, and gocatamig, which is a tricyclic, I believe. And I want to get into antibody-drug conjugates, a topic I was mentioning. We did a whole program at SGO on this. And here we have a bunch of new agents with a new target. and in small cell. But maybe just to start, Christine, this is a slide from your presentation looking at some of the ADCs right now that are being looked at. And you can see B7H3, which is the target for IDXD, is also the target in several other ADCs. There's a couple of DLL3 targets, maybe trying to do better than Rova-T. A couple other agents with different targets. Anything you want to say on sort of the broad strokes of where these things are and when, if at all, you think it's going to come into practice, Christine?
Yeah, really exciting development and data. These are the four main targets would be B7H3, DLL3, SEZ6, and TROP2, the most development in B7H3. And of these, ifinatamab deruxtecan, or IDXD, is the furthest along in development, showing really nice responses in the second line and beyond. Some of their early data, the ID8 Lung-01 study that's been reported already. But as you can see in the fourth column, all of these ADCs have at least 50% objective response rates. Now, while we don't have long-term data, this is an awfully good start for patients who have already seen chemotherapy that we're looking for responses in. Toxicities are primarily mediated by the topo-1 payload, so hematologic toxicities are common across the board. And intracranial activity is seen in almost all the ADCs that have reported it. I think what we do have to watch out for are some of the toxicities. We're not new to this with ADCs as an oncology community, but ILD is a concern. So patient selection is going to be important, and having active management protocols, early identification to know when patients need to have intervention and need to be taken off drug or dose reduced. But all of these targets, with the exception of TROP2, which is not highly expressed on small cell lung cancer, the other ones are highly expressed, SEZ6, DLL3, and B7H3. And I think the question is, they'll certainly come into the second line setting, I think, especially if tarlatamab moves into maintenance, which we anticipate it will. And so how to choose, which one to choose, what biomarkers are we going to use? And then for me, I don't know, for Jacob, one surprise was Isobran, EGFR HER3 bispecific ADC, had a 48% response rate in small cell lung cancer. I do not think of small cells being EGFR or HER3 expressing or targetable. So that was, I'm glad they looked.
So I want to get more into the B7H3. We saw just recently announcement that IDXD is now getting a priority review, and you'll understand why when we take a look at the data for extensive stage disease. But can you talk a little bit more about B7H3, Jacob, how much it's expressed, and what IDXD actually is and what we know about it in terms of efficacy and tolerability?
Yeah, B7H3 also very common on small cell lung cancer, and IDXD is essentially an antibody drug conjugate binding B7H3, internalizes the drug, releases the payload, which is deruxtecan, which leads to cell apoptosis that spills into the surrounding tissue. Deruxtecan has a bystander effect, meaning that it crosses other cell membranes as well. So you don't actually need every cell to express B7H3 and internalize the drug. It can just release that payload across. But like Christine mentioned, the payload has toxicities to it, and we see cytopenias, we see ILD across all of the deruxtecan drugs, datopotamab deruxtecan, ifinatamab deruxtecan, trastuzumab deruxtecan, and patritumab deruxtecan, which is no longer being pursued, but that also showed some ILD. So, many probably have some experience already in the monitoring for ILD in patients getting Dato-DXd or trastuzumab deruxtecan. I think in the small cell space, it's a bit more important, even in that these patients often have less pulmonary reserve. A challenge thing about that is a grade 1 ILD is you just see it radiographically alone. There's no symptoms. And if that's a really mild finding on the scan, then is it real or is it waxing and waning inflammatory findings, which of course we see commonly in patients with small cell lung cancer? If there are any symptoms along with those radiographic findings, that's a grade 2. In the trial, we stop the drug at that point. It does not restart. And steroids are a really important part of the management. And so this will be something to just be particularly aware of as this drug ultimately becomes available. I expect it to be, the response rates are extraordinary. The intracranial responses in those who have not had prior radiation to their brain mets is even better than the systemic response rates, which is quite shocking, but that is true. So the drug looks too good. It's going to be available. So to be aware of these things.
So I'm just kind of curious, Jacob, I know you've done a lot of work on Dato-DXd, which is approved, but in EGFR only, and maybe not that impressive outside of it. I mean, you look at, we can take a look again at the slide. If you look at this waterfall plot and a response rate of 48%, I can understand why I can see people in practice going like, when am I going to be able to use this drug? I don't need a randomized study. But a lot of times it's hard to sort of indirectly compare. Any thoughts, for example, in general, in terms of efficacy of IDXD in small cell versus what you saw with Dato in non-small cell, for example?
Oh, versus Dato. Well, the response rates are higher with IDXD in small cell than what we saw from Dato in the non-small cell population. Of course, if you look at Dato with the EGFR specific, that's going to be better than in the all non-small cell or even all adenocarcinoma. But, ifinatamab deruxtecan relative to the currently available chemotherapy agents, on paper, this looks quite a bit better. The response rates are good. You see the waterfall plot is really the vast majority are having some degree of tumor shrinkage. This drug is clearly very effective in small cell lung cancer. And the response rates in the second line setting being more than 50% is really, that was shocking to me. Now, the durability of it does look quite a bit like chemotherapy. And I think that IDXD, I think of it like a targeted chemo. And that's what I talk about with patients with drugs like this. And patients are often very happy to hear targeted, even though it's chemotherapy. But I think what we're seeing from a toxicity standpoint, from an efficacy standpoint, kind of matches chemotherapy in a lot of ways, which just means that this is all, aside from the ILD, which Christine highlighted, this is all stuff that oncologists are used to managing as well. So I think this will be a welcome addition to the clinic. Where it fits probably earlier is going to be in the second line space if tarlatamab goes to the maintenance setting. Of course, I'm speculating, but we'll see. And then the other big competitors are going to be the other ADCs. You mentioned Rova-T, which failed, a DLL3 targeting ADC. Some of the other DLL3 ADCs look quite good too, though. It says 6 ADC. There's a lot going on in the ADC space.
And we were talking before about intracranial activity, and we see here IDXD, as Jacob was alluding to, very interesting, impressive intracranial activity. We were talking about adverse events, and we'll get to some of the other things, but getting back to ILD, it's always a little, people say, well, the last name or the payload of deruxtecan is associated with ILD. I've heard other people say, it's much more of an issue with TDXD because there are HER2 receptors in the lung. I don't know if that's true or not. Dato was the same payload, and it doesn't look like there's as much ILD. A TDXD people get very nervous about because obviously there have been deaths with that, and it's prompted very aggressive screening. But again, Christine, can you kind of put in perspective how much of the risk is with ILD with an agent like IDXD, for example, compared to TDXD?
Oh, gosh, that's going to be a hard comparison for me to do. But, numerically, it's about 12% we're seeing across the trial. So 1 in 10 patients have had some degree of ILD. I think that number should improve. Well, no, the rate will be the same, but the outcome may be different, that it won't progress to higher grade because patients will have earlier recognition. I don't think I can make a good comparison to TDXD, but I think 10% is a notable number. There are actually, I think, additional screening protocols for patients who would be candidates for IDXD, and so maybe we can redirect patients who might be at high risk for ILD to other agents in that line, in that setting. That'll be just as important.
Any comments on other adverse effects? It looks like the incidence of dose reduction, delay, or discontinuation is pretty modest here. Beyond, and also, I'm curious how aggressive you are, Jacob, about screening for ILD. And are you using? Usually people are going to be imaged anyhow. How do you approach that? What else do you see? You see any ophthalmic issues, acute GI toxicity, some of the other mucositis, some of the other things that have been observed with other ADCs? What do you see with IDXD, Jacob?
Well, the mucositis and eye surface toxicity is really a Dato-DXd. That's a TROP2, I think, toxicity. We see it from SAC-TMT as well in the EGFR space. That's another trial of a TROP2 ADC. In this case, we don't really tend to see mucositis or stomatitis or ocular surface toxicity. Really is more the ILD, which, as you've said, is something that we see across the whole deruxtecan portfolio, and that seems to be more of a payload toxicity than something related to the antibody. It's something to be aware of, something to monitor for in the small cell space. People have less reserve, pulmonary reserve. But I do scans generally every 6 weeks on therapy, maybe 8 weeks, depending upon what they're on. If they're in the maintenance setting after first line therapy, I'll scan every 8 weeks. So, where this ends up fitting in, I'll probably be scanning every 6 weeks, maybe every 9 weeks, depending on how long people have been on it. So they're getting that imaging of their chest to look for this as well.
So, Christine, any thoughts about combining ADCs or combining IDXD with other agents here? I mentioned before gocatamig, again a tri-specific, I guess, sort of similar to tarlatamab, but also the question of combining with IO. Right now, first-line therapy of metastatic triple-negative breast cancer in patients with a PD-1 positivity is an ADC plus an IO, sacituzumab. What about combining IDXD with an IO? Here we've seen durvalumab being considered as well as bispecifics. Any thoughts about where that's heading, Christine?
Yeah, I think this is part of the future. There are multiple ADCs being introduced in early phase studies, mainly phase 1, phase 2, to assess toxicity in combination with IO, in combination with other chemotherapies. I think some trials are really smartly designed to kind of take it stepwise, but it's chemotherapy. And it's in the second line setting, if we're seeing responses of 45, 60%, they are acting just like chemotherapy in the frontline setting. Except that it's patients who have already been chemotherapy exposed. So I think it's really an important pursuit to treat this like chemotherapy, especially with molecules that are highly expressed in small cell lung cancer.
So we mentioned there are other ADCs targeting B7H3. We could spend a long time, as we often do when we talk about ADCs, about what causes resistance. Is it target related or payload related? We'll see how this plays out. But right now, when you look at that waterfall plot for IDXD, you're like, okay, maybe it's time to start using this. Again, here's another summary of what we know about these other agents and some of the studies that are being looked at. You can check out the slide deck as well as the 2 presentations for some of these other ADCs. Sacituzumab, we'll see whether that has a future as well. It's kind of interesting to show up here in small cell. Obviously, a lot of experience with that in breast cancer. But a couple other new approaches. First, I've got to ask you, Jacob, about CAR T therapy. I just learned this morning there's CAR T for prostate cancer as well as a CD3 bispecific, which I didn't know. What about CAR T for small cell, Jacob?
Yeah, we've been involved in a CAR T trial with DLL3, and I think we're seeing a promising signal. Now there is a next generation to that is going to be opening soon as well. The next generation is a much shorter time for cell processing. So we do cell collection, and then this what's been now fully accrued is a DLL3 CAR T that was taking 2 months or maybe a little more for the cell processing. So patients would need to go on a bridging therapy. This new technology will be a couple weeks, and so we'll be able to start people much faster. I'm very excited for this. We've seen a signal of efficacy there, and certainly very well tolerated from a toxicity standpoint as well. So promising, and I look forward to the next study with this.
So, Christine, this is your slide. I really recommend people check out your presentation. You have a great discussion about all these different possibilities of the future. Just wonder if you could just comment on that one in the middle there, the PRISM study. I think that's very interesting. Can you comment?
Yeah, this is a study run through SWOG, led by Ann Chang clinically, and then Lauren Byers and Carl Gare helping with some of the correlative studies. This is a study in maintenance where patients who have received chemo IO have their tumor analyzed for gene expression to determine what molecular subtype of small cell their tumor represents. And a while back, there was some data suggesting that we could really try to subtype based on transcriptional profile, gene expression of the tumor. Based on this molecular subtype, patients are randomized to an arm that contains durvalumab, but also a targeted therapy. And those targeted therapies are switching a little bit as the trial evolves, but really a way to try to further personalize and select patients. Right now, everything we talked about for patients is a one-size-fits-all. We don't have any selection parameters, and I think this is going to be part of the future as well.
I just flashed on the old battle trial that Roy Herbst did at MD Anderson. I mean, the newbies to oncology. That was like one of the first trials really trying to match up tissue with new agents, and now here we are talking about it in small cell. So I want to just finish out on this interesting agent that I know you've had some experience with, Jacob, alisertib, an aurora kinase inhibitor. Maybe you can talk a little bit about how this works and what we know about it and whether you think there's any future for it in small cell.
Well, we'll see. Aurora kinase, this is work that my colleague Matt Oser has done a lot in his lab around aurora kinase inhibitors. I think up to this point, with some of the prior aurora kinase inhibitors, we have not really seen efficacy from those. But this drug, alisertib, has given a signal in the past. Tofika Wanikoko has led a lot of work with this drug, and it is a trial we have open here. I think we are. What we've seen in the past is that, particularly when given with paclitaxel, as the slide you have up, is so alisertib plus paclitaxel versus placebo paclitaxel. It was really particularly in the c-MYC amplification group, that it looks like there's an efficacy signal. What we have open right now is an all-comer alisertib single agent, and certainly looking at a lot of correlative work along with that. This is an ongoing trial, and we're really hopeful that this is going to show a significant efficacy signal and hopefully has a place within the paradigm. I think we're still quite early in that process, even though the story started years ago.
And, Christine, also, when you think about the trials nowadays, and here's another study, another agent, we heard about ivonescimab in the past, a bispecific targeting PD-1 and VEGF. This is it sounds kind of similar to me. Any thoughts about this, or whether ivonescimab is heading anywhere, and particularly in small cells? It's like a pretty good waterfall plot.
Yeah, so this is pumitamig, which is another PD-1. This might actually be PD-L1. VEGF-A in combination with chemotherapy. So really good response rates in the frontline setting. That's what we're seeing here. But I think there's a lot of data to back up using a VEGF or a VEGF blockade in small cell lung cancer. There have been studies throughout the years that have shown a signal, small but notable, when different VEGF inhibitors have been used in the small cell space, whether it was bevacizumab or sunitinib. So there have been hints of it all along the way. I hope to see more of this agent, this molecule, or ivonescimab in the small cell space. We just need to find the right patients.
Yeah, I haven't really associated the idea of VEGF and small cell in the same sentence, but okay, yeah. I'm always open to learn. And here, actually, this is some of we were talking about CAR T, and here's some of the data that Jacob was just referring to. So, Christine and Jacob, thank you so much. So exciting what's going on in oncology in general as well, particularly in lung cancer and small cell lung cancer. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much, Christine. Jacob, thank you so much. Have a great night.